Kelsey, if you want to start, I think we'll be okay as everybody kind of trickles in.
Alrighty.
Thanks.
Welcome everyone to the NEP seminar series. It is my pleasure to introduce our seminar speaker today, Dr. Robert Newton Jr. Dr. Newton obtained his doctorate degree in clinical psychology from the University of Florida and is currently an associate professor and director of the Physical Activity and Ethnic Minority Health Laboratory at the Pennington Biomedical Research Center. He is a member of the American College of Sports Medicine Society of Behavioral Medicine. His research examines the effect of lifestyle interventions on the health of African Americans. Many of these interventions include partnerships with community entities and incorporate mobile technology to foster behavior change. Although most of his work involves developing physical activity promotion interventions, he also engages in weight loss studies. A growing area of his research is lifestyle interventions in older African Americans and its effect on cognitive function. Currently, Dr. Newton leads studies assessing the effect of community-based physical activity interventions in older African American adults and a mobile phone-based intervention targeting increased physical activity in young children. Dr. Newton is also involved in 2 primary care weight management programs and several childhood physical activity and weight management studies. Dr. Newton has obtained federal, state, industry, and private foundation funding to support his research efforts. We're looking forward to today's presentation and learning more. So I will turn it over to you, Dr. Newton.
Okay, well, welcome everybody. Thank you for having me. I greatly appreciate it and hope that the presentation will be interesting and people will learn some things about the kinds of things that we're doing here. And so yeah, I'm looking forward to it. And I will try to leave about 10 minutes for questions and answers. So I'll try to finish around 10 minutes to the hour. So what I'm going to talk today is about just a few of our community-based physical activity interventions that we have going on or that we've completed. And I'll talk a little bit about, how we do some of our recruiting. We'll talk about some of the community entities we're involved with, and then sort of where some of our research is going. And I also have a few slides that talk about some of the results from some of our studies. One of the first things I wanted to do is, because I don't know how many people know about Pennington Biomedical. So I want to spend a little bit of time talking about where it is that I work and exactly what we do at Pennington. And, quite honestly, before I got to Pennington, I didn't know about it myself. So I was recruited here as a postdoc. And I remember when somebody told me when I was on internship, hey, you should come interview at Pennington, and I had absolutely no idea what they were talking about. But obviously I learned about it. So Pennington is it's affiliated with LSU, and it's a 2,200 acre campus in Baton Rouge, Louisiana. We're about 6 miles down the street from the LSU campus. And we don't have any required activities on LSU's campus. So we sort of function like an independent research institution. It was established in 1989 with a generous gift from Doc Pennington. And really, the mission is to discover the triggers of chronic diseases through innovative research that improves health over the lifespan. And although that was not necessarily the original mission, that's what our mission is right now. We have about 60 researchers. This kind of fluctuates. So these numbers as of March 3rd, 2021 may not necessarily be accurate, but we have about 60 researchers, 400 staff. And it's 100% research facility. So we are 100% soft money. Now, there are some investigators who do have some appointments at LSU or LSU Health Science Center down in New Orleans. But most of the faculty does research 100% of the time. And so, we really spend our days in meetings related to our studies. And we spend time, obviously, writing grants, writing manuscripts, collaborating with other investigators. So really just doing research 24/7. And, we're really set up to help people live well beyond the expected. And so I want to show you what the campus looks like. So this is sort of an aerial view of the campus. And I will show you different parts because I think we have a unique setup here. So I don't know if you guys can see that. No, what I want is the laser pointer. Here we go. Okay. So here we have the administration building, and everybody knows what administration buildings do, handle budgets. And, we have our sponsored project here, our library. So we have support for all the research activities that we do in terms of getting grants submitted, deadlines, managing the grants when they come in, hiring, those sorts of things. Then back here is our conference center, and it truly is a conference center. But there are faculty and staff who are here. This part here is new. It's our annex. And interestingly, right now, this area right here is all being used for COVID, or I'm sorry, for the COVID vaccine. So we partnered with Our Lady of the Lake Hospital, and they are essentially doing mass vaccinations for individuals here back in our conference center. This is the basic science building. So we do have a large contingent of basic scientists. So a lot of animal studies that are going on here in this 4-story building. Here is, right now it's a TREC, a children's research unit. There's 2 floors here. We also have metabolic chambers that are basically right about here. We just started a bariatric, we're not doing bariatric surgeries here, but we are doing the assessments for people to have bariatric surgery. So we have 2 bariatric surgeons. So they're currently right here, but they're going to be moving over to this building, which is our imaging building. So we have MRIs in this building, DEXA scanners, and things of this nature. And then here is our outpatient clinic. So the first floor is really just space to do height, weights, to do all kinds of assessments, blood work on participants who are coming in. The second floor is really for the staff and some faculty. And then the 4th floor is all faculty and staff. And this is essentially where my office is. And we also have a hotel here. So when we have visiting faculty, when we have faculty who are new to the area, but don't necessarily have housing at the moment, they can stay in the hotel. You can see we have a swimming pool, and here's our fitness center. So here we have basically a weight room. We have one room that is cardio. We have treadmills and bikes, and then the other room is free weights and Nautilus machines. And so we can run studies here, exercise training studies. And so those are the major parts of the campus. And then of course we have this lake back here that you guys can partly see. It's basically 3/4 of a mile. If you go all the way around, people can fish out there, and the community can. And so larger perspective, this is going to be integrated into a health network, or health network, where they're trying to link like parks and a health district. So hospitals and Pennington and just the Baton Rouge Recreation Department are all trying to work together to make a health district, and we're part of that health district that includes being able to walk around the lakes, and there's a park that's right next by. So anyway, so we have everything that we need in one spot. We have biostatisticians, we have a recruiting department, we have, as you know, our outpatient clinic, we have an inpatient clinic, we have metabolic chambers. So we have a lot of equipment here that allows us to do our studies without having to use anybody else's services. And so, yep, this is where I work. I forgot that I put that in there. So what I want to talk about today is I want to talk to you, give you some examples of community engaged interventions that we have done. I want to describe sort of our process, our thinking, how we conceptualized the project, how we went about approaching it, how we conducted it, the results. And then I'm going to illustrate, provide you some results to illustrate the effectiveness of these programs. And I'll also give you a little bit of flavor for where we're going in the future. So let me start by saying where my interests come from. So health disparities is really what drives the research that I do. So we know that African Americans have health disparities across a number of different conditions: obesity, diabetes, hypertension, cancers, The list really goes on. And we know that physical activity is a modifiable risk factor for many of these health disparities. So not only in terms of prevention, but also in terms of helping to ameliorate the disease or better manage it if you have it. So we know that physical activity is not going to take away diabetes, but we do know you can have better glucose control by continuing to exercise. Then what we also know is that African Americans tend to have lower levels of physical activity compared to standards and compared to members of other ethnic groups. So these really are the factors that drive the things that I do. And as an example of health disparities here is, this is probably from 2014. Not that the stats have changed that much, but it gives you an idea about diabetes prevalence. And so what we're seeing here is that African American males and African American females have higher rates of diabetes compared to members of other ethnic groups. This doesn't take into account undiagnosed diabetes. This is just, an example. More detail about physical activity in African Americans. Again, as I stated, African Americans have lower levels of physical activity. This is when you look at self-report measures mainly. And we also know that their treadmill performance is lower, so lower levels of fitness, okay? And we know that these things are associated with BMI, obesity, estimates of body fat. We know higher levels of objectively measured moderate to rigorous physical activity are associated with lower BMI, and there's a dose response effect. So the more physical activity, the lower your risk. Self-report data shows that African Americans engage in lower levels of exercise, but so do objective measures. So it depends on if you're looking at total activity, or if you're looking at bouts. It's consistent that across ethnic groups, men exercise or record more physical activity than women, but still these numbers are pretty low. If you're looking at, we're supposed to be getting 30 minutes a day, and here objective data showing that just overall getting 9 minutes, but if you do it in bouts, it's only like about 3 minutes. So really depressing levels of physical activity here. And again, because we're supposed to be getting 30 minutes a day and you're only getting less than 10, falling well short of current recommendations. So in order to prevent health disparities, in order to better manage health disparities, in order to make a difference in the health of African Americans, we do a number of different programs. And so really a lot of this started when I was in grad school, and really getting interested in physical activity because a study that I worked on under my mentor, Dr. Mike Perry, while I was in grad school. If I have time, I'll talk about that study, but for right now, we're going to bypass that and just say that one of the things that I learned from that, or that got me curious, are, what are the ways that we can use the community, and what are the different kinds of exercise behaviors that we can have African Americans engage in, or we can target that might improve health in this population. And so I think coming out of grad school, I didn't really have like a specific target. I think, sometimes people have, a disease that they want to address, or they have, more likely a disease, just an area. And so I was very global, and you'll see this in some of the studies that I present, which is really just an example. But it does describe sort of how I'm, in some ways, kind of all over the place. But nonetheless, community-based research. What kind of community entities do we work with? So here in Baton Rouge, we work with the BREC, with the Baton Rouge Recreation Department. So this is a BREC park that's in Baton Rouge. The BREC system here in Baton Rouge is award-winning. They've won a couple of awards for just the number of parks and the activities that they put on. So here's one. I actually play tennis at this park quite frequently, and another community entity is churches. And so I'll go into more detail a little bit about churches, but we do work with churches a number of different ways. And here's neighborhoods. And we've done a program where we essentially work with a neighborhood to put on physical activities for children who are in lower socioeconomic statuses. And so we work with neighborhoods, and then we work with community centers. And we don't work with all of these entities the same, and I'll sort of give you a flavor for how we work with each. Then we also work with the YMCA, and this is a YMCA. All of these are in Baton Rouge. This is a YMCA that is located in an area that is heavily populated with African Americans. It's in North Baton Rouge, and we work with this Y on one of our programs, and we'll more than likely work with the Y in the future as well. So one of the things that is inspiring for me, I think, early in my career was this systematic review that was done by Militia Witt Glover and Shriki Kumanika. And so what they did was they really diagrammed the physical activity interventions that had been done in African Americans. And so they talked about, cultural tailoring, and they had talked about the different ways that interventions had been done and their success, where they had been done, what in community entities. But the thing that caught my attention about this study really was this sentence right here, which says that most studies recruited only women, and women comprised most of the participants in other studies. Only one study recruited men. So what this really told me was that we had a gap in the literature, in that there hadn't been a lot of studies, physical activity studies, that had targeted African American men, despite the fact that, as you saw from the chart that I showed earlier, there's no real difference in the rates of certain health disparities between African American men and African American women. And so it inspired an idea in my head. And so I started to look at some of the literature, and finding out that 15 to 20% of African Americans have diabetes. It's obviously a health disparity associated with many comorbidities. Physical activity can affect insulin, and being a physical activity guy, this was particularly appealing. And again, few randomized studies have been done in men. And so the question really became, can we design an intervention that is specific to African American men that will help them to increase their levels of physical activity, knowing that the levels are not where they're supposed to be? Can we do an exercise training intervention that will be effective in increasing the physical activity? And then will this physical activity then result in changes in insulin function and reduced risk factors for diabetes? So that really was the thinking, the thought process behind this particular study. So the first thing that we did was we needed to see if African American men would even be interested in this kind of program. And if they were interested in increasing their physical activity, what kinds of components did they think that they needed in order to be able to engage in the program and then sustain their engagement in the program? So what we did was we conducted focus groups. So we conducted focus groups with 54 African American men over 7 different focus groups. And we asked them these questions. Basically, are you interested in increasing your physical activity? What are some of the barriers? What are some things that would facilitate you increasing your levels of physical activity? And so we got a couple of things from this. And one of the things that we learned from them is that they felt like they needed accountability. They needed somebody to know that they were exercising, and somebody that they needed to report back to about their physical activity. So we need to have some level of accountability. They also felt like they didn't have very many facilities in order to do physical activity. And we all know that many of us can just go outside and just exercise. You can go to a park, you can do these sorts of things. But the men really wanted a facility. They wanted a place to actually do their physical activity. So we took that into note. And then we wanted to know what their thoughts were about strength training. And as you can guess, most men were very open to the idea of doing strength training. So we kept these things in mind when we designed the intervention. And what this turned out to be was ARTIS. It's aerobic and resistance training on insulin sensitivity in African American men. So I'll tell you a little bit about the design of the study and the hypotheses. So there were essentially, it's a randomized controlled trial where we had 2 groups. We basically had an intervention group, and then you had a control group that essentially got information. So we hypothesized that there would be greater reduction in 2-hour insulin for those men who were in the intervention group compared to the men who were in the control group. We also hypothesized that we'd have greater reduction in secondary outcomes. And you can see those secondary outcomes there. And then we figured that we would have low attrition and high attendance. Okay. That was what we were shooting for. So we established partnerships. And remember, I told you about BREC, the Baton Rouge Recreation Department. So when we wrote the grant, we wrote it with BREC. And we had met with them beforehand and, several times and had established this working relationship. And, they were able to see the grant and see basically that the way that we had talked about it was written into the grant. And then when we got the grant, we had some legal issues with the BREC and they were not able to participate. And so we shifted gears and contacted the Y and said, hey, are you willing to work with us on this grant? And they agreed. So, we met with the head of the YMCA. We told them what the situation was. And essentially within a week, this process was taken care of. So we had all the contracts worked out, the legal issues and things of that nature. And here in Baton Rouge, there's 9 YMCAs. So they're spread out all over town. So they're in areas that are more heavily populated with African Americans. They're in areas where there's not very high representation, and then there's mixed areas. So our healthy living group, essentially this group received information on how to live a healthy lifestyle. They did not receive any behavioral strategies on how to increase physical activity or alter their diet. They just received information. They also received contact from our project manager and a monthly newsletter. The study coordinator and a monthly newsletter. So we maintained contact, but we did not really intervene with these men in terms of altering their physical activity or dietary behavior. So the aerobic plus resistance training arm is the intervention arm. And we specifically, again, here taking into account the fact that the men wanted to do resistance training. So we had them exercise to the prescription. So we needed them to do 150 minutes of moderate to rigorous physical activity. Then, and they could come 3 to 5 days a week or however many days that they wanted. So they could determine how much time they spent on the treadmill. And then they had a prescription for strength training 2 days out of the week. And we worked with the YMCA staff to work with our men. So our staff did not work with the men. It was the YMCA staff. So we paid for memberships and we paid for the time that they spent with the personal trainer. And they spent time with the personal trainer 3 times the first week, which is pretty typical. You have to learn how to use the machines properly, get your prescription, and get a feel for your personal trainer. And then they work with the personal trainer 1 week after, once a week for the remaining 19 weeks. So this was a 5-month program. So the meetings that they had during those meetings during the week that they had with the personal trainer were really just sort of checking up and making any modifications to their prescription. And the trainers worked with us to change prescriptions. So we had certain guidelines that we went by that would determine if we went up in weight or stayed in weight or whatever the situation was, or increased the speed, the treadmill. So that is our intervention group. We were looking for men who were at risk for diabetes. So you had to have a family member who had diabetes, so an immediate, your nuclear family. And they could not be currently physically active. And we needed, a wide BMI range. So it was 18 to 45. And we were specifically looking for African-American males or males of African descent. So the strategies that I'm going to talk about now about how to recruit really were the basis for how we do things now when we recruit. And it's somewhat based on some recruiting strategies that I learned when I was in graduate school recruiting for my dissertation. So the first thing that we did was we realized that, it's been my experience that typical mass media advertisements in the newspaper, TV, radio station do not recruit large numbers of African Americans into clinical research studies. And so I immediately wanted to hire a recruiter who would just go out and recruit for my particular study. So we hired Emmanuel, and he essentially, he worked at the YMCA. So that was good because he had inside knowledge of the YMCA and how things worked. He also had a master's degree, so he had some research experience. And I had met him earlier, and he had met some other people within our department, so he was kind of well known to us. And so we approached him about the job. He said yes, and so we had him going and recruiting for 20 to 30 hours a week. He kind of was left on his own, so he could go out and pursue things as he saw fit. Although we obviously had some guidelines that we wanted him to follow. We did use earned media. So when people heard about the study, so we were able to get on the TV. Emmanuel was able to get on with a participant. I was able to get on. We had some newspaper coverage as well. We did some emails blasts that people were willing to do for us, and we had some social media, which on our personal Facebook page, which is really owned media, Pennington's Facebook page, and the YMCA was willing to put the information out there as well. So we had some paid media. We did do some radio spots that were paid for. We did a layout in the newspaper, and we also did advertisements in a African-American newspaper, or a newspaper that targeted African-Americans. And we did some mass mailings. And I can tell you that the mass mailings were a total failure. We mailed this out to 20,000 people and got one person recruited into the study. So we didn't use that strategy much. How else did we recruit? Main recruitment strategy was in the community. So we had Emmanuel go to churches. He had a schedule of churches that he was going to. He would make presentations. He would stay afterwards and get people's names. Sometimes we had participants who had been in the study and completed, talk with him when he went to churches. He was at health fairs, local businesses that had high populations of African-American men. We were at the YMCA. We went to primary care offices, and so we really just blanketed Baton Rouge with as many outlets as we can. I believe he also went to some fraternities as well, so, and barbershops where we had flyers. So we really did a good job of covering Baton Rouge with all of our recruitment strategies. But another strategy that we used was using community spokespeople. And why we used this strategy was because we needed to build trust within the community. And so we sought out African-American men who had built trust within the community. So one of those people was the mayor at the time, was an African-American male. We had a very popular African-American doctor, the hip hop doc, Ronnie Whitfield, who was willing to work with us, the coach at Southern University, and then a famous, well-known LSU basketball player who he played many years ago, but he has done a lot of wellness within Baton Rouge. And so he was willing to work with us as well. So what they did was they had a testimonial. We allowed them to, state why they felt like the study was important. We didn't tell them what to say. We just asked for them to write a testimonial from their personal perspective. We put this on flyers. We put the information about the study, where to contact, that we were in community, we were in collaboration with the YMCA. So this is what those flyers look like. So this is Dr. Whitfield. And as you can see, he's giving a personal message as an MD and so on and so forth. And then the information that's below what he says is standard. So with the artist symbol, Pennington, and the YMCA. And then here's an example from our mayor at the time. Again, his personal statement followed by general information. So some of the results of the study, we had to get in contact with 677 individuals in order to get 113 enrolled into the study. That's basically the gist of this graph right here. We had 49 who were assigned to the control group and 54 who were assigned to the intervention group. So this is a recruitment results, and essentially our outreach resulted in 89% of our participants coming in. So we had the most success with community outreach. And it's not, we're not necessarily comparing apples and oranges, because you can go to many more churches and you can do mail outs to individuals, although mail outs will reach a larger proportion than what you get at the churches. But nonetheless, community outreach was effective for us. So essentially we recruited 113 middle-aged, overweight African-American men who were not pre-diabetic, but they were close. Um, and they were very out of shape. So we did recruit a sedentary population like what we were targeting. So we have adherence to the prescription and compliance to the number of days of exercise. And basically this was between 75 to 80% for both of these, adherence to the prescription and compliance to the days. And remember, our goal was 80%, so we fell just a bit shy of that. But for an intervention where we're requiring men to go to the YMCA that they chose, they could choose one of five. They were able to choose which one they wanted to go to. We did not, regulate that. And they, were exercising out in the community with a trainer. I think that this is fairly good compliance. In terms of HOMA beta, we saw that there was a marginal significance between the intervention group and the control group. Essentially, this means that their beta cells are functioning better, getting rid of the same level of glucose though, because the glucose did not change. Measurement of physical activity, if we assessed it in terms of kilograms per minute or kilograms of muscle per minute, we still see the same results, which is that those men who are in the intervention group actually increased their fitness over the course of the intervention. And this says week 10, but I actually believe that this is supposed to be week 20 because it was a 20-week program. And then in terms of body weight and composition, we found that there was a significant decrease in waist circumference for these men. So although our primary outcome was, we did not find significance in the primary outcome, we did find other variables that were significant and pointing to affecting risk factors for diabetes. So in terms of your waist circumference, you're increasing your fitness and functioning of the beta cells. So after we completed this study, I realized that we really didn't have a way for the men to continue. Now, we wanted to measure how long they kept going to the YMCA, because once their prescription was over, once their time in the intervention was over, they would then have to essentially pick up the bill. And when you go to the Y, you swipe a card. And so we wanted to monitor this, but the YMCA became very familiar with our men and they stopped asking them to swipe cards. So we lost all of that data, unfortunately. But so I wanted to have a way to maintain physical activity in these men. And so what that developed into was the Mobile Men app, and that we developed a smartphone app to help men increase or maintain their levels of physical activity through a STTR grant. And so we did a little bit of work with that grant, with that app. I'm not going to get into that data right now, but just know that there were steps after that. And we're actually continuing to do some work to some applications, some grant applications based on the Mobile Men app in different arenas. So, again, my work is really focused on health disparities, and the diabetes prevention program showed that 58% reduction in diabetes risk with dietary change and physical activity change. And there was a lot of efforts to really translate this to real world settings like YMCAs, like churches, and many of these targeted African Americans. So essentially it was taking this ivory tower intervention and bringing it down to a real world perspective. And of course, this is relevant because diabetes and obesity, which the DPP targeted, are health disparities for African Americans. And so one of the ways that people tried to disseminate the DPP was through churches. And churches really are a cornerstone of African American community. They've been a source of health information, a source of social support, an area of respite for African Americans for decades. And so a systematic review was done, and it showed that there's been 27 studies that have been done, church-based interventions for African Americans. They're either faith-based or faith-placed. And a lot of these were behavioral treatments. And so they've met up with some level of success. So 70% reporting weight loss, which is good. 38% of increased physical activity. And we see that there's been some changes in fruit and vegetable intake. And so I wanted to take this idea and do a church-based intervention. And I got to thinking about, technology and how, technology really allows us to have greater reach. It allows us to assess information in real time. And it can actually serve as an intervention, a way to disseminate the intervention if you can deliver the intervention materials or the concepts through whatever digital technology that may be, if it's the internet, if it's smartphone apps, whatever that may be. We know that African Americans use smartphones, and we know that they use them to access health information. We know that smartphones are, for many African American families, are their source of the internet. We know that they use text messaging. And so mHealth interventions have been shown to have success. Some studies will say that they're successful. Some, literature reviews, meta-analyses will not. But there's some evidence that they are effective. And so I really wanted to put these two ideas together. And so that resulted in Lean, lifestyle changes through exercise and nutrition. And essentially, as you can probably guess, this is going to be a church-based technology intervention. So at the time that we did the study, only one church-based technology intervention had been done. Few had utilized, had been done with African Americans. And so we really wanted to see if we can combine these two things in an intervention. Will it be acceptable? So through artists, through our recruiting, remember that I mentioned that we went to a lot of churches. And so we developed relationships with these churches oftentimes because we went there and we went back, and then we had other studies that were going on. And so we were in relative communication with the churches. And so we said, okay, let's work with the churches, but give them a program rather than just going there to recruit. Let's do a program with the churches. So we basically put out a call, said, hey, who wants to be involved? And there were a number of churches that said that they wanted to be involved. And there were some existing organizations that we had linked through. A Mayor's Healthy City Initiative in Baton Rouge links a lot of different communities together: hospitals, research institutions, churches, community centers, things of that nature. So there were some existing relationships there. So we asked a number of churches, 8 agreed to participate. We randomized 5 into the intervention and 3 into the control. It was a delayed treatment intervention. So for the first 6 months, we were intervening in our intervention churches, and then we had the other churches basically waiting. And then after 6 months, they got the intervention. 6-month weight loss intervention. Our participants self-identified as African-American members of the church. We didn't necessarily track membership. They said they were a member. Wonderful. You're in the study. We needed to have, everybody needed to have a BMI over 30. And they needed to have a mobile phone with text messaging capabilities, because we were going to do a text messaging study. So we essentially made sure everybody had text messaging capabilities, because we would bring them in, we'd do a screening, we would send them text messages, and they had to respond to the text messages in order to be involved in the study. So, with the delayed intervention, they also got text messages related to sickle cell, strokes, lupus. These are conditions that are more prevalent for African Americans than they are for other groups. And then they received the intervention after 6 months. So the intervention was conducted at the church. So every church had their own group that went on. We needed every church to have 2 community health workers who would be willing to, come in, be trained by us on how to lead groups. How do you deal with difficult people? How do you teach people about behavior change? What are the behavior change strategies? And we served as a resource, obviously, since we were teaching people who really had no experience doing this. So we trained them. We essentially adapted the DPPs. We cut it down to 10 sessions. The DPP and look ahead. We cut it down to 10 sessions, and we sent text messages to folks, and they were about behavioral strategies. So they would get a lesson, suppose it was on, finding fats. And we would send a text message during the week about, hey, this is one strategy for finding fats. Don't forget to try to find fats in your food and avoid those foods. And we had a number of different text messages, so everybody didn't get the same text message. So maybe 2 people may have gotten the same text message that week, but we randomized it. We also give them prompts. Make sure you go out and exercise today. Make sure you eat better. Those kinds of things. And then we gave them motivational text messages, such as, great job, you're doing great, keep it up. We know this is tough, hang in there, those kinds of things. We had 10 sessions over 6 months, and we were able to recruit 97 participants out of all of the churches. And we had 3 dropouts, a couple lost to contact. So we ended up with 68 folks for the 6-month data. Here you can see the sample. It's again middle-aged, overweight population. And if you look at the glucose levels, you can see that these folks would be considered pre-diabetic, because that was one of the criteria. So we needed people to be either pre-diabetic or self-diagnosed as having diabetes. So we got the sample that we were targeting. And something else to note here. So if you look at the gender, you'll see that it is largely female. And what that really shows, and this is fairly consistent across the literature, if you don't put in efforts to get African-American men, you won't. And so I think that recruiting 80 some odd percent, 90% African-American female with just general recruiting strategies, or even through churches, you're going to end up with a largely female population. So looking at the results real quick, we had a significant change in weight loss. As you can see, it wasn't humongous. It was, about 1.5%. And this is not unusual for adaptations of the DPP in church-based settings. So similar weight loss to what others have shown. In terms of glucose, there was a decrease in both groups, but it was larger in the intervention, but not statistically so. So many of you may remember that there was a flood that hit. They called it the 300-year flood that hit Baton Rouge. And this flood hit right in the middle of our intervention. So this did, I do believe, have an impact on some of our folks. This is actually the target that is near where I was living. So that neighborhood that you see way back there, that's close to the neighborhood where I live. I'm just a little bit off to the left. So luckily I didn't flood, but I did have to walk out in knee-high water to get out of my neighborhood for a couple of days. But anyway, so we assessed the flood, and we see a good percentage of people here saying that it did not affect them. So a larger percentage of the people saying that it did. We had a lot of people whose homes had flooded, their place of employment. So this was certainly something that impacted our study. But nonetheless, they were very receptive to our communications. We had a number of people, these text messages were really supposed to be one way. And we had a number of people who responded to the text messages. And we weren't really looking for the messages because we were expecting them to be one way. But when we did find that they were sending us messages, we then started to send back those messages or responses to those. They were very satisfied with the program. We did a satisfaction questionnaire. The weight loss was small, although potentially typical for what you would see. But technology is acceptable to the population, which is really critical. So, we had a church drop out. Your community contacts don't always work out. Technology is well received. The community health coaches was something that was, it was a good find that we could get people and we could get them trained. And certainly we're not the first intervention to do this. There's many other studies who have done this. And we were really concerned about the burden that we put our community health coaches under. Because if you think about it, if you overburden the staff that's supposed to be working with your population, then it's going to decrease the effectiveness of your intervention. Natural disasters can affect your work. I think we all know this now, right? So with COVID, although not necessarily a natural disaster, but certainly something that impacts your work outside of your control. So, one of the things that this led to was the thinking, particularly about the community health workers, that we don't want to overburden them. We want to give them more resources. So we were sending the text messages. So it would be nice if we could specifically target who to send the text messages to. And so it wouldn't have to be everybody. It would just be those people who are struggling a little bit. And then it would be nice if the people had more technology to help manage their weight. So proven weight loss technologies that the people can use. We can interact with the health coaches to make them to really pinpoint those who really need it and send the text messages really to everybody else to help maintain. So we wrote a grant to do this. It wasn't funded, but we got some good feedback, which led to us. One of the bits of feedback was we need to refine our text messages. So we have a study that's funded now to really develop and refine these text messages with the target population. And then we're going to turn around and go back we're going to reapply for the grant and try to hopefully successfully get it funded. So we're not done with that line of research. So we still have our line with African American men going. We have our church-based intervention that's still going. And then a new line of research. So again, health disparities. We're back to health disparities. Dementia is a health disparity. We know that African Americans have 2 times the risk of developing dementia. We know that dementia, as people age, because we're helping people live healthier lives, dementia is going to be increasing over the number of years. And physical activity has been shown to help maintain cognitive function. It's been shown in some studies to actually improve some aspects of cognitive function. And of course, as you would guess, there's very few studies that have been done in African Americans. And so our first foray into this was, hey, and this question hasn't changed necessarily that much, but how do we design a physical activity program for older African Americans, so 65 and older? And will a program that increases physical activity affect cognition? So these were really the 2 driving questions for us. And so this really spawned the PACE study. So the Program for African American Cognition and Exercise. So the next set of studies I'm going to talk about were done with my colleague, Owen Carmichael, and he really gets a lot of credit for raising my awareness to this area. So with PACE, we had some aims and hypotheses, and one of them was to really tailor a program, a physical activity program, and then to determine if we can increase physical activity. And then if we increase physical activity, does it then increase cognitive function? So those are really the goals. So before we get into this randomized trial, I should say that we did focus groups with participants as well. And the focus groups that we did really helped to inform how we designed the intervention. And we haven't yet published that data, so I'm not going to talk a whole lot about it, but needless to say, or suffice it to say, that this strategy of using focus groups to then inform your intervention, or essentially going to the population to inform your intervention, is a strategy that we've used across studies. So So PACE was a randomized clinical control trial. It was an intervention versus control. It was a 12-week intervention. So it was a pilot study. And this time we had Pennington staff conduct all the sessions at the YMCA. And we didn't pay for memberships or a personal trainer. We just rented a room, rented space in a YMCA. And this is where we did our intervention. Supervised exercise 2 days out of the week. So we had them doing, aerobic and strength, balance and stretching, flexibility. And then we also gave them a prescription to do physical activity on their own at home. So we wanted them to get another 2-3 days of moderate to rigorous physical activity at home. So that was the prescription for the intervention. The successful agent group, these individuals attended 12 sessions. They in a group setting at Pennington. And it was really didactic and somewhat social. So they talked about issues that were relevant for an older population. So about budgeting, how to avoid falls, cognition, nutrition, these kinds of things. But they did not receive any cognitive training. They didn't receive a prescription for physical activity, no behavioral strategy. So it was truly didactic. And a lot of inclusion criteria here, but essentially we were looking for African Americans who were 65 to 85 years old and who were sedentary and who were cognitively normal. So you assess them with the MMSE or whatever, they're not coming up as impaired in any way. So an interesting study that came out of this was, while we were doing this study, there was a study that was being done by another group of researchers. And essentially they said that you have to have African-American staff in order to, or they strongly suggested you have African-American staff at all levels. So as recruiters, as the interventionists, and those sorts of things. And we were able to show just the opposite. And we had good compliance and we had good adherence to our intervention. And although the first contact was an African-American man who did a lot of the recruiting, everybody after that could have been anybody. So when they came to the orientation sessions, when they came in for their clinic visits, they could be African-American, a person that they interacted with. It could be a white American. It could be Hispanic, Latino. So we essentially wrote this paper to show that you don't necessarily have to have racially congruent staff in order for your program to work. Although I do think it's important that the first contact, the recruiter, is representative of the population you're going after. we did a number of different measures, accelerometers, and so you see that there's physical function here, there's cognitive function, there's physical activity, there's cardiovascular and metabolic outcomes that were assessed. So after, actually during PACE, when we wrote PACE, we wrote in MRIs, but the funder said no. You don't have enough people to show any effects via MRI. So we turned around and we wrote to the NIH, National Institutes of Aging, and basically did a bigger PACE with MRIs and a longer program to address the scientific gap of all these short-term physical activity programs. And we were able to get this study funded. And really the goals of this study were in normal individuals, individuals who had normal cognitive function, to look at the effects of this physical activity program on cognitive function, brain function and structure with the MRIs, and then physiological parameters. We expanded the physiological parameters from PACE. And then we had this idea like, hey, well, we've always done these things in people who are cognitively normal, so why don't we now try to do it in individuals who have some level of impairment? So we wrote the NIA about a year and a half later, and essentially we're funded to do the same project again. There's some differences, some differences in some of the outcomes and some of the goals, but nonetheless. So that PACE study then resulted in 2 other studies that we are currently doing. So in short, addressing health disparities can be done, a lot of community-based strategies, accepting of technology. These programs work. Long-term effects remain to be seen, and how to maintain your communications with the community is really critical. Making sure that you have a really collaborative relationship and not one that's one-sided. And so we're trying to move from a community-engaged research where we consult to community-based, where we working together at all stages and empowering the community entity to sort of, handle their end of and have responsibility for a particular part of the grant. So thanks to a lot of people, a lot of collaborators over these projects, and we have great staff at Pennington. I can't say enough about how great of a job that they do. Our community partners in terms of our spokespeople, the people from the churches, YMCA folks have been great, and obviously the funding agencies. So with that, I will stop and take questions, and not doing too bad on time.
Thank you very much. We have a couple questions in the chat actually that we could start with if you'd like.
Yeah, that works.
Okay. First one, are your focus groups in-person interviews or mailed surveys, or how do you identify who you will survey? Okay,
real quickly, our focus groups have always been in person. So we do general recruiting. So we put out advertisements, flyers, we go to churches, the same sorts of recruiting that we would do for the larger studies, we do for the focus groups. And we essentially have people come in, do group consents. We have everybody introduce themselves. We pitch questions or statements to them, allow people to talk. We record the information. We transcribe everything, and we use that in grants. Now, in terms of using it to write papers and things, we don't always do that because I don't really have a qualitative scientist, and my mind is much more interventionist than it is qualitative science. So I've struggled to really put those papers together, but that's how we've used focus groups. We haven't used focus groups during COVID, so I don't have the experience of using it via Zoom or conducting them via Zoom.
Thank you. And then do your spokespersons volunteer their time, or are they paid?
They volunteer their time. We do not pay our spokespeople. And you really have to be careful with your spokespeople. We have not had any bad experiences with spokespeople. We've actually had spokespeople speak when we didn't know they were speaking, and on behalf of our studies. So, I mean, that's a good thing that they've taken it on. It would be nice to know exactly what they said, but I'll take my chances with that one. So yeah, we tend to get people who have some personal investment in the issue that's being raised.
So how long was your recruitment period, and what was the length of time it took to recruit your cohort?
So that it's varied. So PACE, we recruited in a year. We recruited the 56 people in a year. For artists, I think we had a 2.5-year period to recruit, and we recruited in 2 years. We recruited faster than what we had anticipated. For rate, rate was going slower than all the other ones. I'm not exactly sure why. And then COVID hit. So it really got slowed up because we had to stop. So we stopped rate and rate MCI, and we are going to get them started next week. And we will be doing in person. So we're going to have personal protective equipment. We're going to space people out. We're going to tell everybody all about our, the ways that we're going to protect folks. But we're going to do our intervention in person with that one. So that'll start up next week. So it's in short, recruitment has varied, but we've never really missed a target.
And do you see that most participants continue to stick with their physical activity even after the intervention? We know that you mentioned that you did try to follow up, and there's a little bit of research on that.
Yeah, so that's been one glaring issue, is that we have not been able to do a lot of follow-up. So yeah, I have to do better with that. We have not been able to do follow-up. So I told you what happened with artists. So that kind of happened. And we haven't really written into our grants to do follow-up. And I think that's just kind of typical with, your RO1s or your, these grant mechanisms, is that they fund you to do something for a certain period, but they don't fund you to follow people afterwards. So we've struggled in that area. So we really don't know too much about if people continue to exercise after the interventions are done. But that is a direction that we want to go. We just have to sort of figure out how to really make that happen and how to track people over the long term.
You're right. That is a common thing that a lot of folks are now looking for too, is that follow-up data and starting.
Yeah.
So.
Yeah.
All right. And then what are the barriers for African-American men in physical activity, and why do you think women are more involved in your studies?
Okay, so two things. I think that in general, women participate in research more than men. So you have that going in, and that's irrespective of ethnic group. And I think there's some reasons for that. I think, as a man, we sort of see ourselves as like, okay, I got to provide for my family, and that particular thought may be more prevalent in, well, maybe it manifests itself differently in different ethnic groups. And so that charge is taken to a different level, and therefore there's less time. I also believe that, and of course, socioeconomic status can make a difference. So let's not deny that to some level, ethnic minorities and SES are somewhat correlated. So you do have a larger population that are in lower SES environments, and that makes it a little bit difficult if you're trying to truly manage like the funds for your house to survive, to then take time to do research. I also believe that African Americans in general don't have a whole lot of experiences with research and may not have as many as other ethnic groups. So, for example, I'm growing up, my mom and dad said nothing about research. They had never participated in a research project. My dad had gone to college, but he went for math, so he wasn't really doing a lot of, physical activity types of things. He wasn't involved in a lot of research. And it was, so I just didn't see it. And then when I got to, college, that's where I first started to experience it. But I just think that a lot of African Americans don't have a lot of research experience. And let us also not forget Tuskegee and the other experiments that the atrocities that went on. And I think that, especially for an older population, that still resonates. And so they're just less reluctant, to do research, and they're less trusting. And I also think that that's a large reason why it's important to go face to face when you're recruiting ethnic minority populations, because I think I say they, but we, you really need to see a face and be able to ask questions and be able to get a sense of a trust in the person who's presenting. And, quite honestly, I said that, I think that the person they should see should be of a similar background, but that doesn't always work. So down here in Louisiana, I do not sound like somebody from Louisiana. Okay. And so, I have a little bit tougher time than my recruiters who are from Louisiana, who are from Baton Rouge and from the area, and they know people and those sorts of things. So I think that those are the reasons why African American men are harder to recruit, because men in general, because of so to some level SES, some beliefs about providing for the family, just experiences with research and research atrocities in the past.
Great. So did you plan for the differing levels of subject understanding the research plan? And was the amount of time spent with the subjects different depending on how the staff felt they understood the protocol?
Repeat that again. I'm sorry.
First part of it was, did you plan for differing levels of subject understanding the research plan?
No, we did not.
So Robert, this is my question. It's Elizabeth Parks. And if we say you've got an hour to orient someone, that can be very different depending on their reading level, their understanding, if they've ever heard of science or research before. And so I've tried to figure out, shall we enter someone when we feel that they have a level of understanding of what we're asking them to do? Otherwise they come back after a week and they hadn't put the accelerometer on because it didn't occur to them they were supposed to wear the, you know what I mean?
Yeah, I do. So, we do, okay, so we don't do some sort of literacy, health literacy assessment, but we do try to do our orientations and, at 6th grade level or whatever, so that we were trying to cover, everybody, in terms of being able to understand. We also sit down one-on-one with people with their informed consents. And we allow people to ask questions. I mean, obviously everybody's supposed to do this. We make it a point to really sit down and go through and answer every question that's asked and explain things in detail and provide examples as much as we can. So if we say an accelerometer, we're like, here, this is an example of an accelerometer. We have had very few people who we felt didn't understand. And if they don't understand, it's the people who are trained to do this who identify it. They get a sense, okay, this person's just not comprehending. And so then we either, take extra precautions with that person, or they just don't enter the study, or we recommend they don't enter the study, or whatever the situation is. But is there some global thing that we do? No. We rely on, 6th grade level and the skill of our people who are doing the assessments, the informed consent.
We find out what they didn't understand after they start, because they say they understand to us. You know what I mean?
Yeah, I do. And we've just been fortunate. We haven't had people, and we do a lot of run-ins too. So, we say you have to wear the accelerometer and come back with X number of days, or else you're not in the study. And like I gave the example before, do you use text messages? Yeah, I use text messages. Wonderful. Well, we're going to send you a text message and we expect you to respond. And those people who don't respond don't get in.
Okay.
And maybe our run-ins are addressing, what you're talking about, but we do a lot of that with our studies before we let people in.
Yeah, I find it, just one last comment is, I find that our what we're asking them to do is so much that there is no way anybody could understand it sitting down the first time. So we tell them on the phone, then we do the consenting, and then I will ask them before they start the study, what do you think will happen to you? So I get to hear their view of what they heard, right?
Wow.
And sometimes they haven't heard a lot of it. We just find.
Yeah, we don't, that's not a bad idea. We don't typically ask them that question, but that's not a bad idea. So I appreciate that suggestion.
Thanks.
Yep.
Quick question. Do you find that you have to incentivize your subject, your participants, in terms of like paying them a decent amount before they are more willing to partake in a study, or just the idea that whatever they are doing is going to impact their health in a positive way is enough to get them?
Yeah, this was interesting, because when I was in grad school, we didn't, at least maybe this is my memory, I don't remember us incentivizing. I don't remember us, paying participants. And so when I came to Pennington and they were paying people to do visits, I was like, this is very foreign. We don't do this. But the culture here is, you provide compensation for people coming in, taking their time to do your assessments. And the assessments that we do at Pennington probably are a little bit more involved than at other places, or maybe not other places, but when I was at University of Florida for that particular study. So Yeah, we do provide compensation. So is it excessive? I don't think so. You know, it can range anywhere from, you know, if you're doing focus groups, you're looking at $25. That's, you know, I don't think that's coercive in any way, shape, form, or fashion. You know, for our interventions, it could range anywhere from, each visit could be, you know, 50, let's say about $50. And you may have to do 3 or 4 assessment visits over the course of the study. So,
And also, it may depend on how invasive the procedure is. The more invasive, you probably may want to pay them a little bit more.
yeah, that's true. So we, you know, there's a difference in the pay between the two. I told you about rate and rate MCI. Because rate MCI has more invasive procedures, requires them to travel, you know, to do the one thing that we can't do at Pennington, we do compensate them more than what we do for rate. So yeah, you're right. There is a level of compensation. And, you know, we also have that metabolic chamber. I don't necessarily use the metabolic chamber for a lot of my studies, but we have, you know, the inpatient unit. And if you stay inpatient, it's lucrative, you know, certainly.
Have you ever partnered with LSU Extension faculty or anyone to help deliver programs or even take your interventions more statewide?
So no, okay. So we have done statewide interventions, but that was through schools. And then another statewide intervention was through healthcare systems. So no, we have not, I personally have not worked with the extension agents, although we're trying to partner with some extension agents in a current application. But it has not been a big part of the things I've done before, but people do work with extension agents at Pennington, the LSU extension.
I had a question about, so when you do your community-based testing, do they still come to Pennington to do their pre and post, or do you try to do all your measurements and things in the community?
Yeah, so we've done it both ways. So, you know, for the larger studies like ARTIS and rate MCI and PACE, we do our assessments at Pennington. But for, you know, a smaller study, you know, like lean, and some other studies we've done, we do our assessments out in the field. And it really depends on, a lot of it depends on what are the goals of the study and the funding that's available. So, you know, because ARTIS was really about, well, you know, PACE, I think rate is a good example. So we need to do MRIs on people. Well, we simply can't do MRIs in the field. So that is one study that has to be done at Pennington. Whereas lean was body fat assessment and questionnaires, and we could do a finger stick. So that was done, you know, out in the community. So it really depends on the study.
Thank you.
Any other questions, thoughts?
Man, it's 10 after the hour. I just noticed what time it was. Thank you so much. I don't see anybody else raising their hands, and I think I didn't even realize we took up so much more of your time, but thank you.
Can we unmute, please?
Yeah, you can give a round of applause.
Thank you.
Thank you.
Thank you so much.
Very
That
welcome.
was fantastic. I think we all learned a lot. Obviously, the question and answer went for almost 20 minutes, so. But we appreciate you taking your time. Thank you for visiting Missouri.
You're very welcome. Maybe next time do it face to face.
Yeah.
Yes, definitely.
Bye.
All right, everybody. Thank you for your time.